as we move on, we are having Lisa coming up to present on making prevention work for young MSM, bridging real-world needs through digital engagement. Lisa is working with the University of North Carolina at Chapel Hill, so could we put our hands together and welcome Lisa? Seems to be asking for instructions. No, she's not seeing her presentation come up.
We're good. We're just mixing it up. So thank you so much for inviting me. I actually spoke at CROI in 2004 in San Francisco. So this is my first time speaking in 15 years at CROI. So I started to wonder what I've been doing for 15 years. But I think I actually threw up before that presentation, so I was pretty nervous. So right now I think I'm okay, but if I get nervous, just grab me. So I'm going to talk about making prevention work for young MSM, and it's actually great to follow Sinead because I think a lot of what I'll talk about for young MSM, she already sort of presented, so thank you, in terms of what's being done in young women in South Africa. So, using my Mac. We're good. All right. So you already know the problem if you've been here this whole time, and I'm assuming since you've stayed to the last day, you've been to other sessions. But we've learned a lot about PrEP and treatment as prevention and how it can impact the care continuum, and yet we still have gaps. And to address these gaps, we really need to think more about comprehensive prevention, interventions that can really optimize the biomedical options that we have. And I think as we think about this, we need to consider what digital tools we have and how they can be effectively leveraged to engage young MSM in prevention and bring the virtual to the real. So we are a mobile generation, all of us. Youth are more avid users of the internet, of social media, but my guess is every one of you, I can look out and see you're on your phones, you're taking pictures. I won't do a show of hands of who sleeps closer to their phone than their partner, but I do. And so there are tools that are near and dear to everyone's heart. In one of these studies, they found that people would be really distressed if they couldn't check their phone for a day. And again, I'm guessing every single one of you would feel the same way if I took away your phone. So we need to sort of recognize that they're already ingrained in the lives of the folks that we're trying to reach for our interventions. And this spans the continent, the world, and while there are some issues in terms of access and uptake, we really are continuing to see a rise and an increase in digital tools really across the globe. And so, when we think about smartphones, which we'll talk about a little, there are places where smartphones, there are more access, but regardless, youth are online and they have access to online interventions, and we should be thinking about this and not leaving some of these sort of developing countries behind and assuming that folks don't have access. In terms of the continuum, there's been a lot done. Everybody wants to make an app, and there, is a reason that we look at mHealth in terms of allowing for anonymity, social support, engagement, real-time assessment, and feedback. And it can cut some of the issues that Sinead presented in terms of, getting to adherence clubs. You can actually use technology to bridge those issues. We've done a lot of work on feasibility, acceptability, which shows high levels, but we haven't yet sort of really proved the sort of efficacy. There aren't long-term studies for a lot of these approaches that show long-term sustainability, scale up, and cost. And so that's really where I think the field is moving as we think about sort of my next 15 years, I guess, of sort of work, hopefully. So when we think about technology-based platforms, you really have sort of your basic phone, which most folks, even in least developing countries, don't have at least a feature phone, and that has sort of the features of a basic phone calling, but you can get online with Wi-Fi, you can send SMS or pictures. And then smartphones, and they have more capabilities than most of us sort of use or know how to use, but really can kind of tell where you are, what you're doing, GPS, accelerometer, so it tells how you move, Wi-Fi, Bluetooth, text, all that good stuff. And so when we talk about using digital tools and technology, there's lots of things we can do. And obviously in this talk, I'm not going to go in depth into every single one of them. But there's SMS and WhatsApp, web-based or web-optimized interventions. There's apps. Social networking using sort of, whether it's sort of a Facebook or a Grindr. There's telehealth, which there's a great poster on ePrep, which is telehealth-based prep we'll talk about. Virtual reality, AI, intelligence, wearables, electronic adherence monitors, lots and lots of cool things. I think for me the point is that there's all these technologies. If you want to use technology, you're going to think about incorporating technology in your intervention. The first question is why? Do you need it? It's cool, and we all want to be cool. But is technology going to make the intervention more effective? And if the answer to that first question is yes, then how? So how is it going to make your intervention more effective? What pieces of technology actually are going to do something different that could be done in person? And maybe that's just to make it cheaper or more scalable. That's fine. But what is it that the technology is going to do? And that really depends on what your target is, what your population is, and what your health outcome. We also know a lot about what youth and young MSM want. So we've done a lot, and we, not just me, all of you out there as well, have done a lot of work sort of trying to understand what are the preferences for mobile-based interventions, comprehensive interventions. We don't probably actually need to ask these questions anymore. We know that folks will ask for connections to peer and providers, inclusions of discrete reminders. They don't want reminders that say, take your prep, take your art. They want comprehensive, holistic, accurate information. Their lives are not just about HIV, right? Their lives are not just about PrEP. They want to know how to have really good sex, right? They want to know how to stay healthy. They might want to know how to quit smoking. They want to know how to talk to a partner about relationships or come out to their family, or just know what's going on in the world. So we need to think about that while we think about HIV every day, all the time, the people that we're trying to reach don't. They want it to be fun, right? So games, incentives, rewards, other ways to make it more fun, and they want it to have attention to privacy and confidentiality. So these come up time and time again, work in the US, in Thailand, in South Africa, right? Over and over again. Now, the cool thing about, mHealth interventions is that they're sort of, you get them on your phone, they're there, they're cool. The bad thing is that it's really easy to delete an app. Right? Again, most of you probably have deleted an app today that you downloaded, right? And so it's really easy. So how do we make things sticky? How do we make folks sort of stick with what we want them to do? Again, there's been a lot of work by folks to sort of think about what are these, how do you make apps or mHealth-based interventions engaging? So tailoring, make it sort of relevant, personalized. Foster peer support. We heard about that by Sinead in terms of in-person interventions. Same thing online. Include these game-based elements or gamification. Provision of self-monitoring and feedback. And inclusion of push factors, notifications, reminders. Again, all of these things are what we're starting to see kind of included in these comprehensive packages, and there's evidence behind it. So what are some tools? How can we sort of think about, and this, I'll try and be a little bit provocative, but, where are the gaps in our continuum of care for young MSM, and maybe where can technology address some of these gaps? 2 interventions looking at online risk. And so Keep It Up is an intervention by Brian Mustansky and colleagues. It's an online modular type intervention which was delivered at STD clinics and found reductions in STD rates. Health Empowerment is an intervention that myself and my team at UNC designed. Was really designed to be a stigma reduction intervention where sort of building our own community where folks could talk and engage. And we found reductions in CAI. More importantly, I think we found that among those that were HIV positive, lower CAI in those with detectable viral loads, so understanding some of the messaging around U equals U, which we heard a wonderful panel yesterday. And we found stigma reduction. So folks that were talking and engaging in reductions or in conversations around stigma with their peers, both positive and negative, we saw reductions in stigma, which translated into better care outcomes. We know that we need to do better at testing. And there's lots of different barriers to testing for young MSM. This is data from the Youth Risk Behavior Surveillance Survey in the U.S., but we know that not everyone who needs to get tested is getting tested. So how can we use technology to address testing? Social media is one way. This is a meta-analysis conducted that looked at different social media-based interventions that might address testing and found some improvements. So data from 4 studies showed that HIV testing uptake increased. A lot of times they used already established platforms like Facebook or Grindr to either offer testing, to provide peer support on the social media platforms, and then also to offer STI home-based testing kits. Technology-supported HIV testing, I think, again, regardless of, how youth-friendly and MSM-friendly our facilities are, there are some folks that are still going to have barriers to accessing them. So how can we improve uptake and use of self-testing? I think some of the, concerns with using self-testing in the past are, particularly around youth, are what happens if they get a positive result? How are they going to link to care? How are they going to interpret it? How do we link them to prevention services if they have a negative test? And so technology can help address some of these. So either online platforms to distribute testing, smartphone apps that include the ability to sort of assess for risk and then order test kits through the app. The affordability of video conferencing so that youth could actually have somebody walk them through the test. And then there's some other test technologies that have some novel sensors that can tell kind of when a test kit's been opened so that it can trigger follow-up. Here's sort of a social media / testing intervention that was launched in Vietnam, just to show that, again, using sort of social media, Facebook, an established Facebook page, they were able to kind of rev up followers, which led to more people getting referred into care, more people getting tested, and then those that were getting tested getting diagnosed. So what about PrEP, sort of the next step in our continuum? I sort of see 3 gaps, obviously between engagement and uptake, between uptake and adherence, and between short-term adherence and persistence. So if we think about gap 1, engagement and uptake, so this is a study out of Atlanta which looked at a cohort of young black MSM who were offered PrEP, and did a really kind of neat analysis where they went back and looked at the 14 folks who had incident HIV diagnosis during the study. And interestingly, the majority of those did not start PrEP, so 10 out of the 14, even though, again, they were offered it. And when you look at sort of the reasons why folks didn't start PrEP, you really start to get at I think, some of the same concerns that we heard in the earlier presentation. Low risk perception, concerns about side effects, stigma. And so where can we sort of have technology-based solutions to address some of these gaps in the continuum? So self-monitoring tools. So my friends at UCSF have an online risk calculator called SexPro, which helps incorporate sort of risks that includes kind of both individual behaviors as well as sort of geography, and can help monitor in terms of risk perception, and the CDC also has some online estimators, helping providers with technology learn sort of how to ask the questions so that they're not so focused on sort of this same old risk questions they seem to always ask, so we can get more youth onto PrEP. Concerns about side effects, again, these are easily sort of addressed in apps. This is a screenshot from an app we developed around side effects, but forums where you can sort of talk about side effects, and stigma. And so how do we address stigma using technology? I think certainly one attempt, and obviously it's not the panacea, but one thing is to start having conversations. And so having peer support groups, presentation of sort of role model stories, other folks who can provide online support, share information can be very helpful. What about gap 2, maximizing adherence? This is from the elegant study that Sybil did as part of the ATN, where looking at youth who were on a PrEP demonstration study and found that adherence really declined over time. And it was really markedly declined when the visits were spaced out. So when folks after week 12 went to less frequent visits, adherence dropped. So this has been observed in the U.S. as well as globally. And so how can we use technology solutions to address this? So enhanced visit schedules that can be delivered using telehealth platforms, SMS-based platforms we've heard about in the PrEP study that sounds like Connie and Sinead are leading around WhatsApp groups or SMS reminders, and then increasing the intensity to more in-person if needed. And then you can certainly think about technology-supported peer navigation, in-app-based counseling as well. Here's some work that's been done. We've seen a lot of work with SMS, and I think the data is clear that SMS is feasible, acceptable, it works. It has modest benefits. It's, again, not going to work for everyone, and it may not work in sustained periods of time for more than 6 months to a year, but it works, and it probably should be included regardless in packages of interventions. We know that SMSs work better when they're not sent daily. This is at least for ART, when they're supported by bidirectional support. So, I think Connie's presented, they're just going to say, "What's up, girlfriend?" I think I read on the slide, and I'm assuming they can write back nothing. And if they write back, "I need you," then they'll call. So that's supported by the evidence, and then personalized content. So, "Hey Lisa, how you doing with your meds?" versus what are you doing? This hasn't been done as much for PrEP, although there's, again, the group in San Francisco has done a study using an SMS-based platform that also has additional features called PrEPmate, which did provide tailored SMS messaging and found improvements in attendance and study visits as well as adherence. My group at UNC has created an app for both PrEP adherence and ART adherence. So it's sort of a comprehensive app. We call it P3, Prepared, Protected, and Empowered. The app is built on sort of a platform that allows for addresses all of the features that we found to be important in terms of engagement, social support, monitoring, feedback, incentives, both virtual and real-world incentives for usage, and in that portal that we can deliver integrated next-step counseling through the app. So we've had some pilot results that show some preliminary improvements, both in PrEP adherence as well as ART self-management, and we're working to roll this out within the Adolescent Trials Network starting this month in an RCT. In addition, we're working with folks in Thailand and South Africa to, we've in both settings have looked at feasibility and acceptability of the app, and it's to date been shown to be high. So being able to sort of take platforms and rapidly adapt them to other settings, I think is important. What about optimizing persistence? This was a study of a radar cohort of 16 to 29-year-old MSM who had been on PrEP and stopped. The main reasons were trouble getting to doctor's appointments, insurance issues, they lost their insurance, or didn't think was at risk. So all sort of ways, things that we can address with technology. So telehealth platforms for engaging with providers in between or in lieu of visits. So there's been research in public health, PrEP at Home, PrEP Tech, ePrEP, PrEP Iowa, as well as commercial providers that will allow for sort of telehealth visits so folks don't have to come in every time they want to test. It's tied to home-based STI testing, HIV testing, so really making this sort of, as my friend Aaron Siegler says, sort of getting PrEP on your couch. And so how do we sort of think about kind of larger expansion and again, putting some of these tools together, your testing, your PrEP at home, your app for adherence, and so on. So where are we headed? So this is a slide that highlights some of the work we're doing within the Adolescent Trials Network. So myself and colleagues work on a study called ITEC, which is a UNC Emory Center to address technology for youth across the care continuum. We're running 10+ studies, which are all using technology-based tools to address the prevention and care for youth in the U.S. The majority of these studies focus on young MSM or young trans women, and our goal is to enroll over 3,000 people in these studies we're in year 3 of 5. So almost all of the formative work has been done on these interventions, and they're all being rolled out in RCT in the next few months. Avatars, agents, and chatbots, so sort of taking the field forward. So these are 2 interventions that use avatars or chatbots to provide information. The first one is a personal health guide run by Mark Durkin in Chicago, which is sort of a health concierge that's helping African-American young MSM navigate care. The bottom one and to the right is Tough Talks, which is intervention by our group, which facilitates disclosure of HIV status and helps youth make informed choices about who to disclose to, when they should or should not disclose to, and really sort of empowers them to think about disclosure as it impacts their life in a sort of holistic and sort of longitudinal way. So what's next? I think, again, moving from sort of testing SMS-based interventions. Again, my personal view is we don't need another intervention that just tests SMS, but to put it into ongoing implementation studies, doing kind of the work that Connie sort of is doing in her study of stepped care interventions. Also thinking about other formats for SMS. Most youth don't send text messages that have a lot of words. They send emojis and GIFs and memes and videos and other funny things. I mean, that's what I send too, but, and they don't read. So, thinking about as we're moving forward in these interventions, how can you make what you're sending them, maybe not every time you have to say, "What's up, girlfriend?" Maybe you send them a meme of a funny giraffe. I don't know. A peacock, something that is engaging, that's funny. They like sort of that stimulation, and it makes folks remember things. So, thinking about how we can actually do that. When size matters, again, not an audience participation question, but is sort of the next wave of sort of thinking about big data. There's a lot of information we can get from social media, people's interactions on social media, posts, and they can be analyzed. This is being done in fields of drug use, eating disorders, schizophrenia, to sort of understand how people are posting, and if that information can then be used to design different interventions. Again, I think there's ethical considerations that have not yet been fully worked out, but I think it's certainly something that we're going to see more and more of as we move forward. I would say that if you're going to do online or mHealth-based interventions, think about the data you're collecting, understanding how users move through these interventions, what pieces they access, when, and how, and make sure you account for that, so that at the end of the day, we can actually understand what components of interventions work, and not just the intervention in of itself, and that will allow for larger scale-up. And again, Sinead stole my thunder, but moving beyond the RCT, the future is adaptive, right? These trials, mHealth tools were not meant to be developed and stay the same for 5 years. My guess is that if I told Apple that they couldn't change their platform or their operating system for 5 years until we test it, they probably wouldn't talk to me on the phone anyway, but they wouldn't do it, right? And so we're sort of forced into this idea that we have to test an intervention for that long of time without it changing. So how do we think about learning and adapting our interventions based on what we learn? And there's a lot of different alternative trial designs. I am not a trial designer, by trade, but there are a lot of folks that are thinking really thoughtfully about how we can actually evaluate these interventions in a more real-world way. So at the end of the day, 5 years from now, we actually have an intervention that can be used. So our path forward, I think we need to continue to think about technology, even if you're not delivering a technology-based intervention, you're using technology to recruit your population of young MSM, to retain them, and to engage them in your prevention efforts. And so we really need to continue to think about how do we sort of make use of the tools that youth are using, but also respect their privacy and these spaces where they also are able to sort of be themselves and express themselves. I think we need to think more about usability, affordability, scalability, sustainability, and longer-term engagement, and understand what we mean by engagement by intervention. Some mHealth interventions don't need to be used for 5 years. Maybe you can use it for a month and establish the habit, or maybe you use it for a month and then you have it available. So how do we think about kind of evaluating how folks need to use these interventions? And then I would say we need to stop recreating the wheel. Every time somebody needs to develop a new app, there's things that we already know. There's platforms that are already built. There's extensive content that has already been written that we don't need to every single time start from scratch. So how can we work together in a more cohesive manner to build on what we've learned, to build sustainable platforms, to build content libraries that can be updated based on information that becomes available without having to start from the beginning each time. So I want to special thanks to some folks who helped me with my slides, and then my group at UNC and within iTech. So thank you.
Thank you, Lisa. That was great and really comprehensive. Thank you. So if you have questions, if you could walk to the microphone. And while they're doing that, I'm just wondering how to bring fun and education together so that they don't just get excited about it and then it ends there. Because one of the key things that really bothers me is how to raise the risk perception, how youth can appreciate the fact that they are at risk. And I remember I worked on the FemPrep. It came as a surprise that, the people who seroconverted during the study, when we went back to them for qualitative interviews, like, I couldn't believe he would do this to me. I couldn't believe he had another partner. So it's like they don't believe they're like in this enclosure where they don't think their partners are cheating on them or something like that. So I don't know how you can comment about making it fun, but at the same time making it educative so that then they can get a lesson out of it to apply it to themselves.
Yeah, I mean, I guess I would say, what do you do for fun online, right? And what does anybody do for fun online? So where do folks go? I mean, they go to social media based. That's the number one sort of things that folks go to are social media. And why do they go? It's fun to sort of see what other people think. It's fun to comment. It's fun to have other people comment on what you say. So that is sort of one piece, right? Incorporating what is known to be fun outside of this world, the world of HIV prevention, so that folks want to use it. And then the other thing people do online is games. And so, how do you sort of think about sort of making things, I say gamified, because we don't have the money to design Fortnite. My son would like me to, but we don't. That's not our role. We're not game designers. So, but how do we sort of again encourage, incentivize, but then make that a place where they actually want to go because they get something out of it? So we have to provide the return investment so that they want to come back.
Okay, thank you. If you could ask your question.
Yeah. Lisa, that was a great talk. Thank you very much. Anatol Melon Jansen. I was going to ask you about apps and the utility of creating apps. Melbourne Sexual Health developed an app for MSM in Australia, and they found that nobody wanted to have it on their phone, just like a lot of people delete Grindr and then reload it. And so they went for responsive programming as a way of making sure that people could just use a website, and of course that makes it much easier for people to dip in and out of it. And I was just wondering your thoughts on that and how many of your apps are getting deleted or not used.
Yeah, I mean, it's a great question. I think that's the big question, right? And so it's part of it is the design from the beginning, right? Of sort of, how do you make it sort of not a specifically sort of prevention app, right? So, that it's not sort of a big red ribbon, right, on the app, which was, something I had to learn. And so I think finding ways for folks to access it in multiple ways. So a lot of times in the design currently, we use a lot of React Native so that you can actually access it from different platforms if you don't necessarily want it to be an app. But apps have certain features that are beneficial, right, in terms of sort of some of the features that you can access in terms of accessing them when you're not necessarily connected to Wi-Fi in terms of monitoring and tracking. So I think we try and weigh the benefits of what behavior we're trying to address with the technology tool we design, recognizing also that some people are going to delete it. And so, that's just the nature of it. And really starting to think about how do we build features within it itself that actually makes it sticky, that makes them want to use it. And, I don't have all the answers to that. If I did, I would, I'd be great.
Just to follow up on that, are you thinking of using...
I think we only have a couple of seconds, and I want him to ask that. But remember, when you're asking, you're next. And so you're eating into your time. You can ask.
I'll be quick.
Lisa, that was a great talk. So I was wondering about kind of real-life aspects of these apps, because, we would love to be able to use something like this, say, for PrEP adherence and persistence, but the reality is someone has to check, someone has to answer, who's going to reimburse? Like, how does that happen?
Yeah. I mean, I think, the hope is that we can get to a place where we actually are doing sort of dissemination implementation of these. So my hope is that we can prove that they're effective, and then they can be available in the real world. Because when you actually start to boil down the costs, once it's developed, there is maintenance cost. It's not free, but you should be able to, it's a much lower cost than delivering in-person intervention. So.
Okay, thank you. And